Ryan Stanton here with ACEP Frontline, joined today by Dr. Rachel Liu. You've been on the podcast before and really big into ultrasound and some fantastic courses here because it's next level type stuff for the emergency physician, and one of our higher yield opportunities in ultrasonography on the bedside, and that's our use during ACLS, cardiac arrest and resuscitation. And you are doing here, you've got the actual lecture as well as multiple labs on ultrasound guided ACLS lab and resuscitation. And I think that's a fantastic topic. And so when we're here at ACEP 50th anniversary, I thought let's go straight to the experts on this and get some fantastic information. So thanks again for joining us again on the front line.
Thank you.
So let's talk about it. You know, we've talked about some of the ultrasound guided stuff in the past. This is a specific utilization. Talk about the evolution of ultrasonography in ACLS.
I think where we're really going with this is, in line with the fact that we are not seeing that much increased survival in out-of-hospital cardiac arrest for those people who, land at our doorstep. We, despite many expensive mechanisms, we've really, by doing ultrasound guidance, over the last few years have started to see why this may be happening. And so the talks I'm going to be giving are really about using transthoracic echo, specifically for cardiac arrest monitoring of compressions and compression location. And we think compression location is key. I'll show a number of examples of with manual or mechanical devices, how the actual location of compressions is not correct, and how when we move our location of compressions, the patient achieves ROSC or their end titles go up and they have parameters that are more consistent with life.
It is interesting that what this allows us to do is better evaluate the status of what we're accomplishing. So PEA is not necessarily PEA.
Right.
It gives us a better actual visualization of what the heart is doing at that time. And interesting, you talked about chest compression location, because I know that's one of the discussions about the mechanical chest compressions is the issue with the fact that we're not seeing improved survival, the fact we're pushing on the aorta, on the root of the aorta, not on the actual ventricles.
Right, and that's exactly what I think it is. It's nothing wrong with the mechanical compression device. What's wrong is the one-size-fits-all approach that is the ACLS guidelines or the CPR guidelines, right? So we're treating each individual death the same. And we're not accounting for anatomic factors or individual physiologic factors that does not fit the one-size-fits-all model.
It's, for those that are just getting into this, and we're talking about, from the ACLS standpoint of ultrasound, what kind of skills. So you're going from the ground up. A lot of if you're out in the last 15 years, you're probably certified anyway. But at the same time, the technology has gotten so much better and things have gotten so much better that even with me being a certified ultrasound, cardiac ACLS applications weren't necessarily really part of the focus. And so it's still, even if you're familiar with ultrasound, getting familiar from an ACLS standpoint. So what are the skills we need to know in order to effectively use ultrasound in ACLS?
I really think it's not very much different from the skills we have now. It's just we're looking at it in a little different way after years of observing cardiac arrests using standard TTE. So everyone learns, the parasternal long, parasternal short, apical. But if you can imagine, these areas might be encumbered by Zoll pads or even manual hands, slipping and sliding. And what we're doing is essentially trying to look at the LV in any way possible. Whether that's doing your apical but modifying it to be right next to the Zoll pad sticker instead of your traditional apical place, doing high parasternal views and pointing down into the chest wall to try to achieve parasternal views, and of course your subxiphoid view that you might be familiar with. The only problem there is the mechanical compression devices can throw your hand off the patient's body during actual compression. So we're taking the standard views and just modifying them a little bit, and not expecting the perfect views that you see in the textbooks and lectures.
But it's not about a perfect view. I'm not getting images for a inquisition by radiology on
Right.
my pictures. I'm really just trying to get a decent view, what I'm looking for, and that's So what am I looking for?
Specifically, we're looking for, as we said already, where the location of your LV is, and you don't necessarily need ultrasound for this, but appropriate depth, speed, and compression of the LV with full recoil to, promote forward flow of your circulation. So really, you're looking at specifically at the LV for compression location and compression adequacy. In addition to the etiologies like effusion or tamponade, RV size for PE, and so on.
What are some of the good ways that we can use throughout? So you mentioned some of the early initiation, and I will a lot of times use the ultrasound throughout.
Yep.
Having a probe on somebody the entire time, not
Right.
necessarily the chest. What are some of the cool monitoring things I can do with the ultrasound during the processes of cardiac arrest?
So you mean monitoring like heart-wise or monitoring anything?
Anything. I mean, the things that we can do. I mean, one thing that I like to do is to ensure that our chest compressions are adequate. I will a lot of times put the ultrasound down the femoral area and
Sure.
monitor the flow, follow the pulse wave.
Yep.
Making sure that everything looks good from there also lets me know where I'm looking.
Mm-hmm.
The pulse checks should be gone.
Yeah.
Because Doppler flow is such a better way of evaluating whether there's something there, because so many times when somebody does or does not feel a pulse, it is or is not there in just the
Right.
opposite way.
Yeah.
But that little puff of yellow-red.
Right. And we have to understand, too, that anything that we're talking about right now isn't achievable on 100% of patients. But, looking at the femoral region to see if you're getting, decent circulation during the actual compression. And what some people find easier is actually looking at the carotid,
Yes.
assuming that there's no C-collar on or whatever. But those are two new things that might actually be help, Some people look at the IVC if they can get a good view, just to see if it's flat or plethoric. To see if they're dealing with an obstructive picture or a hypovolemia picture. But, these are all kind of hard. You have to pick which patients you do things on and tailor a thing. Don't spend too much time if one thing's not working.
Well, if you think about what we've done in the past, so ACLS, traditional CPR, pulse checks with your hand, stethoscopes for hearing lung sounds and things like that, direct laryngoscopy for intubation. If even now, we're falling away a lot from intubations in ACLS, and now we're to the point now where we got mechanical. We can monitor placement. We can monitor efficiency. We can monitor end-tidal CO2. Whatever airway management we're going to do, we can do active monitoring internally with the ultrasound, and
Yep.
so it really does give us a better idea. And really, more importantly, is we all know that ACLS, the recovery is high-quality CPR and then identifying and correcting reversible causes. And ultrasound's a great way to start evaluating for many of those
Exactly.
reversible causes as things are going on.
You can even do it as you're doing compression monitoring. You can get that instant diagnosis, etiology, treatment plan, and compression monitoring all in one view on certain people.
Yeah.
But, it's also the reason why many of programs are looking at transesophageal echo for cardiac arrests, for example. And there's places that have started it already. And so this is a new frontier for us.
Well, I think for most of us, I think getting everybody on board for external ultrasound
Yes.
is probably the first step.
The lower hanging fruit, yeah.
Yeah. I mean, going for transesophageal ultrasound for most of us is kind of like going straight from peripheral IVs to Riboa.
Yeah.
We baby steps here. Baby steps, Dr. Lou. We need to start working our ways slowly
I will say,
there.
though, it's not that hard.
Well,
Not
I can
too hard.
imagine
Not
it's
that
not. There's a
hard.
lot of stuff in healthcare that's not that hard.
That's true.
I mean, IO, you'd think
That's true.
everybody thinks is like the craziest, hardest thing ever, and it's like super easy. And so, once you learn it, a lot of things are not that difficult. But we have to evolve. I mean, in order for us to start getting better numbers, we have to
Right.
better be able to assess how we're doing it, so the high quality,
Yep.
and then how we can reverse whatever's going on.
And I think what's really interesting is with the advent of these pocket devices that are literally going to hit the market in the next 2 months, whether we can train paramedics to do some of these ideas that we're talking about, so we're not getting 45 minutes of essentially non-viable compressions and no parameters of life. If they can start that from the get-go, maybe we'll have better out-of-hospital, ROSC.
Yes, and well, I absolutely. I think
Yeah.
that's the next big step. We've already seen that transition, the move of ultrasounds into the EMS world, and really the only thing that's really held it back has been just the limited amount of space that you have in the ambulance to put a machine. And so now with that advancement of higher quality but very portable and rugged machines, you can do incredible things, and now I think you're going to see it explode
Yep.
in the pre-hospital setting.
Yes.
Not just for cardiac arrest, ACLS type stuff, but for a lot of different things as well. It's just going to make that care that much better. And, we were talking about some of the monitoring, some of the reversible causes, some of the things that I see, the big things that are obvious, the person who goes down is a pulmonary embolism, all right? What's that right ventricle look like? Is the potential for tamponade?
Yep.
Is there an effusion? Pneumothorax? Aorta, how's all that stuff doing? And you can work through that, while you're doing your monitoring, you can then work through those sorts of things and really start to see, one, do I have something that I can reverse? Or two, is this really a futile care effort?
Right. And after it's been going on for a while, you can automatically maybe assume some futile care, but is there something that could either lead us to a decision to prolong or call it right there?
And that's it, the calling, and that's where PEA
Exactly.
is a great option. If my monitor's got a lot of activity that looks
Right.
organized, but my heart is not on
Doing
board.
anything, yeah, then that would be your pseudo PEA.
Yes.
And you can call it, But it's training people to realize the distinction, because we also know that we disagree amongst ourselves on what counts as organized rhythm and what doesn't. So the more we see these, the more we'll know.
And there's always going to be debate, but the numbers are low, and what we want to do is we want to be able to maximize our numbers, really focus on the ones that we can get a functional recovery, and then knowing when to say when.
Right.
When we're not going to get somebody back, because we know at some point everybody's going to be on the not coming back side of things, and
Right.
and so we don't need to waste an hour and a half, 2 hours with all the resources, time on something that we know we're not going to get back. So, it's one of those things, fantastic use of technology and advancement from the ultrasound world. And Dr. Liu here is talking about the talks and the labs that she is doing. And with these labs and with your education, what are some of the challenges that you see, the mistakes that we often make, or some of the things that really, that are much easier, that people are doing a lot better than they expected they would do?
I think the first step to see that's great is, taking someone from ground zero, and within an hour, they're able to get cardiac views and are pretty happy with that. But once you get beyond the views, it's really, some of the most overcalled things we see are, whether someone has a good EF or not. An EF is meaning ejection fraction. In the code arena, of course, no one has an ejection fraction. So that actually makes it really difficult to tell what your heart is when it's not beating. So looking for some of these etiologies might be difficult when it doesn't look as normal as you practiced in a lab.
Mm-hmm.
In our lab specifically, we will mimic hands on someone's chest like they're doing compression, so that people can get used to snaking their probe into, between providers' hands. We're going to practice some left-handed scanning, because that may be helpful to you when you're doing code, monitoring. And we're just going to have discussions about pathologies. There's going to be examples about pathologies, and specifically the PEA, pseudo-PEA arena, what that actually looks like on an ultrasound clip.
Do you see, future future machinations of the ACLS, where we're pulling a lot of stuff out, and it's been a pretty thin course recently. We don't have many medications left. We're not really
Right.
focusing on the airway. It's really just high-quality CPR. Do you see the ultrasound becoming a primary education point for healthcare provided?
I would really hope so. I think because we currently have this one-size-fits-all approach, that's what everyone goes through, I would hope that ultrasound would get implemented in there. The AHA have already mentioned that it can be used, but it's not part of the guideline, like, for instance, it is in the ACLS guidelines now. So, yeah, I would hope that things progress to the point that it gets included. Once there's more research that tells us more about timing of echo, when to do echo, what the best means of doing it are, and how else it can help.
And as you know, with ATLS, the mentions of FAST were followed not too far thereafter by a significant focus on the ultrasound, and then shortly after FAST became the eFast,
Right.
where we start adding expanding up vertically as well, and start to really add more and more. I mean, ultrasound's really in its heyday right now when it comes to technology catching up with our needs in emergency medicine, matched with our skills and education set as board-certified emergency physicians and those around the arena of emergency medicine and pre-hospital medicine.
For sure. Yep.
Dr. Rachel Liu, how can folks get in touch with you if they have any further questions, comments, thoughts, whatnot?
I am reachable on Twitter at RubbleEM or email rachel.liu@yale.edu.
Fantastic information. Always love having the conversations with Dr. Liu. This is now at least our second. I'm not sure. I don't know if we did multiple at first one, but the second time we've talked, you're definitely going to be a regular, one of our go-tos for definitely for the ultrasound side of things, and keep us posted on what's new, exciting, and help us make us better and more proficient physicians and other providers in medicine. Thank you very much.
It's been a pleasure. Thank you.
As for me, you can contact me, youreverydaymedicine@gmail.com, youreverydaymedicine@gmail.com, @everydaymed on Twitter. And until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.